From the American Neurological Association, I'm Adeline Goss. This is ANA Investigates. Parkinson's disease has long been a clinical diagnosis, but recently there have been proposals to redefine the disease based on biomarkers of alpha-synucleinopathy and dopaminergic dysfunction. A similar shift has already occurred in Alzheimer's disease. Our guest today, Dr. Michael Okun, is Professor of Neurology and the Director of the Norman Fixel Institute at the University of Florida. He co-authored a viewpoint in JAMA last summer arguing that there would be benefits to a biological definition of Parkinson's, but there would also be risks. He'll unpack both sides of this debate today with Dr. Christine Doss Esper, movement disorder specialist and associate professor of neurology at the Emory University School of Medicine. Here's Christine.
Welcome, Mike. So happy to be here with you today.
It's my pleasure. It should be a lot of fun.
Can you get us started off by framing the current debate on how we should be defining Parkinson's disease? At a high level, what would you say are the two sides of this debate?
Yeah, so if we sort of step back and think about what are the challenges with Parkinson's, it starts with that simple issue, which is Parkinson's one disease? And we know now that it isn't one disease. And then we move to that question, is Parkinson just a disease of dopamine and loss of dopamine? And we know now that Parkinson is not a disease of just dopamine and loss of dopamine. And so we have to ask ourselves, what is it that we can measure that's going to allow us to create a definition of a disease? And so we have scientists now on one side of this debate saying, okay, we can get to a biological, a very definite, measurable, way that we can say this is Parkinson's disease. We've got to get as close as we can get because this is what's going to drive the next generation of research, drive our clinical trials, and help us to develop therapy specifically for Parkinson, even if it isn't one disease. And we have people on the other side of the debate saying, wait a minute. One, not so fast. It's not so easy. And two, this isn't one disease. Three, it's not just a disease of dopamine. And so how are you all going to do this?
Interesting. So historically, just thinking about how Parkinson's has been diagnosed, how would you describe that as compared to these new definitions that are being proposed?
Yeah, so we for many years and even up to this day still talk about making that diagnosis based on going to a healthcare practitioner. They put together everything that they can from asking you questions. They examine you and they say, okay, now we're going to give you this medicine called dopamine and see how you respond. This has sort of been the classical way that we have approached the diagnosis of Parkinson. It's clunky. It's not perfect. If you see people lots of times, you can get a sense of what they have and what the diagnosis is and the correct diagnosis. But we have a crisis of not enough specialists. We have a crisis of, the capacity for people to be seen and evaluated in this way and followed. And even when we do all these things and we do it with trained specialists, we can be wrong 10 to 20% of the time. So that's the current state before we get to, could we measure it with something like a quote biomarker?
Sure. So as opposed to some of the in-person clinical exams that we do today, the technology is certainly changing. Can you briefly review some of the more recent advances we have in diagnostics for Parkinson's disease, and why might you select one over another?
Now we have a couple of more things in our armamentarium, and one of those things is we can do a nuclear medicine study where we can inject something in your vein and have it go up to the brain and tell us about the dopamine transporter. It's called DAT or DAT imaging. It's not actually dopamine. They're looking at the dopamine transporter, but it gives us a picture of what may be going on in the brain with dopamine. And when it's one side is lost more than the other and different patterns, it gives us a clue that there's something going on. Now, it doesn't tell us whether you have Parkinson or something that looks like Parkinson, which is a limitation of the scan, but it can help people to get to that next step. The other newer technology that we have seen is skin testing. And we know now that Parkinson isn't one disease. We know it's not just a disease of dopamine, and we know it's not just a brain disease. And it's actually in the skin and in the body and in many organs like the gut. And so it turns out that you can get a biopsy and you can see alpha-synuclein in the skin, the abnormal form of that protein, and that could help to advance you toward diagnosis. Again, Parkinson isn't one disease, and there are also diseases that have that protein present in them that aren't regular Parkinson disease. And so it helps to advance the field forward. And folks have talked about MRI scanning making a comeback. People have looked at cerebrospinal fluid, and folks are starting to look at things like your spit and any sort of area that might have something measurable that will give us a clue. And of course, the thing that, I don't want to say the Holy Grail, but if I was going to say the Holy Grail, people would want like a simple prick or blood test that would be able to do this cheap and effectively. And so that's sort of where we're at right now. Summary: clinical examination, response to dopamine, this DAT study, which doesn't tell us specifically if you have Parkinson's, but gives us a clue. Same with the skin biopsy, could give us a clue.
Thanks, Mike. That really was a great overview of imaging and alpha-synucleinopathies. Really shows how things have changed over time. How would you say this relates to the recent proposals for the biological definition of Parkinson's disease?
Okay, so now it gets interesting, fun, and sometimes a little bit of frustration, right? Because now what you're going to do is you're going to take what we have available and you're going to try to smash it together and create some sort of measurable biological system. And two systems have emerged in recent studies that were published here, just put out there, for people to start to look at. Neither one is perfect. One is called the neuronal alpha-synuclein integrated staging system, or NSD system, and the other one called the synergy, a little bit more fun system. And these two groups have really cleverly put together things that might be measurable from research that is going on to try to come up with a staging system that might get us closer to being able to measure Parkinson's disease. And so both of these systems allow use of things like the dopamine transporter scan. One of them, the Synergy, allows some other imaging modalities as well. And I think the first system is probably going to also allow that at some point. But they are not looking, interestingly, specifically at the signs, for diagnosis. They're really looking at the measurables, and both systems have to deal with real questions in the field, like why some of the tests don't show up positive with certain folks with certain Parkinson's genes and how we should classify them. And so they're both trying hard, Christine, and they're dealing with, some really difficult problems.
So, this really sounds enticing given this day and age and how we are considering disease modifying therapy and biomarkers, but still seems a bit premature. What would you say are arguments in favor of these proposals? And what would you say are major risks of these proposals at this time?
Yeah, so I think that it is really tantalizing to say, hey, wouldn't it be awesome if we had a way to measure, Parkinson, to make the diagnosis accurately and to do this across the globe in a way that, would be practical, would be affordable, and would allow anybody, even a general practitioner or a person in society, in the farthest reach away from technologies, to be able to prick the finger or something and get an answer. And if you could get closer to an answer like that, Christine, then it could really, advance the world, not just in diagnosis, but also in identifying people and putting them in the right clinical trials, identifying folks early. And for those listening, we still don't have a treatment that's going to slow disease progression. But if we can get to that, and we expect that we all get up every morning thinking that we will, then we're going to need a way to measure it and a way to measure disease. And so the challenges moving forward is even if you solve problem number one, which is sort of, classification by a measurement system, we still have to detect disease progression over time to see if our therapies are actually working and how well they're working. Once we're able to do that, we're not going to have to enroll thousands of people into a clinical trial. We'll be able to do this with much smaller numbers. Now, the things that we worry the most about if we go too fast on a Parkinson staging system is that, it could have repercussions in triggering a crisis of accessibility, of affordability, of acceptability. And we often say, simply stated, a lot of people and a lot of countries could be left out. Remember, it might not be easy to get these things, and then all of a sudden you can't get a diagnosis. And then, of course, there is this long-standing philosophical history about dropping eponyms. So the eponym Parkinson disease for James Parkinson is what people recognize as Parkinson. And so if we drop this and we decide it's actually something else, it can actually change the optics and change access for people. And so it's really important that we tap the brakes and consider what could happen. And we also consider that if regulatory agencies like the FDA act too quickly and say you have to do X, Y, and Z, and lots of people in lots of regions, not just in the US, but around the world, can't do this, then you won't have access to therapies and you won't have access to clinical trials. And so there are a lot of considerations on a lot of layers of this, societal considerations as well as the medical considerations and the treatment and long-term prognosis by monitoring. So there's a whole bunch at stake here.
Yeah, there's a lot to consider, I'd say, from the scientific standpoint, as well as globally, including various implications. In addition to what you have mentioned, some have also proposed integrating dementia with Lewy bodies, or DLB, into the biological definition of Parkinson's disease, what they call a Parkinson's type synucleinopathy. Can you elaborate on this?
Yeah, absolutely. So just, for listeners to know, it turns out that the pathology, the abnormal proteins in Parkinson's and in Lewy body are either close to the same or identical. They have different clinical courses, and there's a long-standing debate about whether it's the same disease or different diseases. So leaving that debate alone, you can imagine when you design a system to try to measure something, if it comes up positive in both diseases, is it one disease? Is it two diseases? Do they separate? Do they clump together? It's a real question, in the field. And we know that as we begin to look at things like as we measure this protein, you're going to come up positive in a lot of these cases with diffuse Lewy body dementia, Lewy body disease, whatever term that you use. And we have to start to make decisions is this one disease or not, or maybe for certain clinical trials, maybe for certain considerations it is as a classification system, is it the same or different disease?
Thanks for that overview, Mike. Certainly challenging, many things to consider. Given the increasing prevalence of Parkinson's disease, some may say this is an opportune time to hone in on the disease modifying therapies, like we have mentioned. That being said, neither one of these definitions make a clear distinction between prodromal and clinically manifest Parkinson's disease. And how would you say this lack of distinction would impact research, would impact clinical care, and, potentially the patients themselves?
Yeah, it's huge, Christine, and it's confusing for people out in the field, for clinicians, for persons with disease and for families. We use the term prodrome, maybe a little bit too loosely, is what we're learning over time as the last decade of papers have come out. And is it truly prodromal, or are these just, early manifestations of the disease itself? And these are early manifestations, and how do we define them? And they can be different across different folks. And then understanding the very earliest manifestations may help us to direct therapies. Also, understanding the pattern of how these evolve may help us to predict what's going to happen for people as we get more data, so that when we're asking all of these important questions, those of us that practice medicine are not sure that the questions that we're asking, how they're going to affect prognosis and how we should reflect the information back to the person that we're sitting with. If this is so confusing and challenging for, those of us in the field, imagine what it's like watching from the outside when you're really the insider with Parkinson's. And so a lot at stake here.
That's right, Mike. Really puts it in perspective. I would say these really are exciting times for us with some of the more recent technological advances we've experienced in the management of Parkinson's disease. Can you expand a bit more on how you think this will impact the disease globally? I know we have certain resources, I would say, here in the US, but I think we need to think big picture. There are certainly populations that may not benefit from this simply due to the limitations.
Yeah, and it is something that we really need to pay attention to. It turns out that when we bring more diverse groups to the table, as we talk about the challenges, we realize that there are many countries, and in fact, double-digit countries that don't even have dopamine. So then you talk about the burden of financial investment that's going to be needed to comply with any global biological standard. That could prove unattainable for underrepresented populations. So we've really got to think about the inclusivity, and don't think, those of you that live in the United States, that we escape any of this. There are lots of regions and lots of places where there can be crises of accessibility, affordability, and acceptability. And so it is, a real challenge.
Thanks for that overview. I mean, certainly we need to think about potential financial, ethical implications, even with insurance. I'll say, Mike, our perspectives, like you and I, may certainly be different as we have observed the evolution in Parkinson's disease care over the past 2 decades, from life-changing surgical interventions that we both specialize in to biomarkers. If you can say a few words to junior investigators in the field today, what would be your advice to them with respect to the biological staging of Parkinson's disease?
Yeah, I mean, my advice, might surprise you, and it's lean in, don't lean out. Okay. When there's a challenge, when there is a controversy, when there are, questions to be answered, that's the call to action for all these young people to get involved. There are many questions that are going to need to be asked in a very deliberate and organized way, that are going to be important to the field, that are going to have impact. And it's going to take a group, it's going to take that next generation of folks to get in there and ask the difficult questions, do the experiments, and bring the data back that will help to guide us. Because we can't continue on the course of the experts deciding what's best for everyone. At the end of the day, we need to ask great questions. We need to be scientific. And sometimes when there's a controversy, we as mentors or coaches to young people tell people, oh, stay away from that. That's controversial. I say opposite. I say lean in, try to learn as much as you can, listen, get involved if you can. If you can, even design one experiment or answer one question that helps in a clear and concise manner, that can help us on the path.
Well, Mike, it was a real pleasure to have you talking with us on this podcast.
Oh, Christine, it's was really a lot of fun, and I think that we covered a lot of important ground here.
That was Dr. Michael Okun, Professor of Neurology at the University of Florida, interviewed by Dr. Christine Doss Esper, Associate Professor of Neurology at the Emory University School of Medicine. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Michelle Johansson. I'm Adeline Goss, podcast host and executive producer. Our production team this month included Christine Doss Esper and Jen Hurley. You can listen to past episodes of our show, subscribe to us so you never miss an episode, and access all of the ANA's educational programs on the Education tab at myana.org. That's it for ANA Investigates. See you next month.